Good evening, everyone, and welcome to tonight's Viva Learning webinar, Don't Sleep on Glass Ionomers, How Glass Ionomers Can Benefit Your Patients in Your Practice. My name is Joshua Austin. I'm a restorative dentist in San Antonio, Texas, and I am an editorial director and columnist for Dental Economics, where I have a column called Pearls for Your Practice, where I get to review new products and materials that come out. So anytime a new bonding agent or adhesive or composite or impression material comes out, the company send me a big box of it to get to play with, and so I've gotten to try and play with a bunch of different things, and it's really is a great gig that I enjoy immensely, and part of that has been getting to see the growth of glass ionomers. I taught for 5 years in the Department of Restorative Dentistry at UT Dental School in San Antonio. And this was the textbook that we used when I was on faculty. It's also the same book that we used when I was a student, written by our program director, Dr. Jim Summit, and just a real hero of mine. And, I distinctly remember my first restoration when I was a junior in clinic, like probably most of us do. We remember that first time we had to do something other than a new patient exam or a periodic exam or one of those diagnostic type of visits, when it was actually time to put a handpiece on a tooth and do some real dentistry. And that experience, which I'm going to share with you in just a second, really scared me away from glass ionomer and kept me from using glass ionomer for probably over a decade of my career, and I think probably to my detriment, to my patient's detriment, and to the detriment of my practice. And we're going to talk about why that is, and what things you can predictably use glass ionomer for in your practice that you might not be, and where you could really see some benefit. But that first restoration I ever did, I remember it just like it was yesterday. It was class 5 non-carious cervical lesions on 19, 20, and 21. And your very typical non-carious cervical lesion, sclerotic dentin, all that kind of stuff. Little recession, all the good stuff that goes into those. And I remember the night before being really excited, and so I opened up this book, the sort of Bible that we went by in San Antonio, and flipping to the chapter on cervical lesions, and reading about all the different techniques and possibilities of things that I could do. And so just like any amateur wanting to try to impress their faculty, I wanted to read up and be ready. So I came to the clinic the next day, and my presiding operative instructor that day was this guy, Dr. Dave Overton, who has now passed away. God rest his soul. He was a great educator, a great dentist, and we miss him immensely. And Dr. Overton was my attending that day, and walks by at 1 o'clock and asks what I'm doing that day. And I said, "Oh, Dr. Overton, I'm so glad to see you. We're going to do a couple of class 5 restorations today, and I've read all about it, and I know exactly what I'm going to do, and I'm ready, and I know what technique and what method I'm going to use, and I'm excited to get going." And he's looked at me and he said, well, how are you going to do it? What technique are you going to use? What material are you going to use? And I said, "Dr. Overton, I'm going to do an open face sandwich technique on this." And he looked at me sort of incredulously and asked, "What is an open face sandwich?" And I kind of remembered at that point that it wasn't an open face sandwich technique, it's an open sandwich technique. And so I remember him rolling his eyes at me and telling me, "Good luck with that. Let me know when you need some help." And I think I had tipped him off from the beginning that maybe I wasn't quite ready to do that technique. And any of you that know that technique, that's a fairly advanced technique. and probably not great for a rank amateur doing their very first restoration. But as most of us know, an open sandwich technique is where you do a layer of glass ionomer, at the gingival margin, and then layer resin composite on top of that, so that you get, all of the at the gingival margin, you get all the goodness of glass ionomer, and then you get the beauty of composite on top of it, and everything is supposed to work great, right? Well, glass ionomer, especially those that we were using at that time, is a little bit more difficult to handle than resin composite. So about an hour into the procedure, I barely had a rubber dam on. I had barely done some kind of preparation. I had glass ionomer on the tooth and on the rubber dam and on the patient's cheek and all over my glove, and it had kind of congealed together in all one big form, one big mass, and it was just a huge mess. And about that time, Dr. Overton walked by and just said, maybe we should start with something a little simpler. And I never forgot that experience, and I never forgot sort of that feeling of panic of not being able to handle the glass ionomer well and causing such a big mess that I just sort of told myself, never again will I use glass ionomer. And so I really didn't for about 10 years. And a new product came out a few years ago that I tried and really liked it. We'll talk about it towards the end tonight. But it really opened my eyes that there are some cases where glass ionomer really does work great, and we shouldn't ignore that. So, I try to put the open face sandwich incident with Dr. Overton out of my mind, and I'm trying to move on and become a more competent and well-nuanced restorative dentist with the materials that I choose. So the objectives for tonight, number one, is to talk about the advantages of using a glass ionomer as a direct restorative material. Why would you do that? What could you get out of it? What would be in it for you and the patient to do that? If there were no advantages at all, we wouldn't be having this webinar. Let's talk about the applications. Where are the best spots in your practice to use a glass ionomer that will be beneficial for you and for your patients, and hopefully strengthen that relationship between you and them. And then we're going to talk about a couple of new glass ionomer restorative materials that are on the market, and some techniques and instructions for use on those materials. So let's talk about the advantages of using glass ionomer, and there's quite a few actually. The number one, I think, in really my opinion, is the fact that we actually get a true bond to tooth structure with glass ionomer. So when you're talking about glass ionomer, you're talking about, if you want to get real technical about it, a polyalkanoic acid polymer matrix. And there are carboxyl groups in that material that chelate the calcium and hydroxyapatite and actually form an ionic bond with the tooth structure. So it's really the only material we have that ionically bonds to tooth structure, specifically dentin. When we're talking about resin composite, we use the term bonding, but we're not really bonding. What are we doing? We're really getting micromechanical retention, right? There's not actually a chemical bond there. Well, with glass ionomer, we actually do have a chemical bond. So that's a distinct advantage, especially when you're talking about working with dentin, which we all know is difficult notoriously to get long-term, resin adhesive bonds to. This is a really nice answer for those situations. Another thing about glass ionomer that is really nice is that the coefficient of thermal expansion is very similar to tooth. And when I say tooth, I'm really kind of referring to dentin more so than enamel. The two are fairly similar. The coefficient of thermal expansion for dentin is around 8, for enamel it's around 11. But when you start looking at composites, the coefficients of thermal expansion start getting over 40, 45, 50. And so those are vastly different, so almost 5 times as much coefficient of thermal expansion as you would find with tooth structure. So that can create some issues for us. With glass ionomer, we have a much more similar coefficient of thermal expansion to dentin, and so that's why I think another reason why glass ionomer works so well as sort of a dentin replacement. The main thing that we think about with glass ionomer is fluoride recharge and release and recharge, however you want to look at it. But that's sort of, if you were to just hold a gun to someone's head, hold a gun to a dentist or a dental student's head and say, advantage of glass ionomer, that's usually the first thing that people will spit out. And there's been all kinds of debate in the literature about whether or not that's all that important. And I think that it is really. I mean, there's good studies that show that we get less recurrent decay around glass ionomer restorations than we do really any other kind of restorations, including amalgam, right? So there's good data that shows that. There's also some data on the other side that shows it's not as big of a deal, but in a lot of those studies, they had the high-risk caries patient restored with glass ionomer and the low-risk caries patient restored with other materials, and there's not really any offset for that in some of those studies. And so I think the problem is that the high-risk caries patients are going to have a higher rate of caries no matter what. So it's a little bit misleading in some of those studies, so you have to be careful. But really, I'm going to show you later a really big systematic review that does show a significant amount of less decay around glass ionomer restorations than amalgam, which is impressive. We think about favorable pulpal response, and when you put a glass ionomer in, there's kind of an initial period of it being pretty acidic, and that can actually be somewhat irritating to a pulp. But that acidity balances out really quickly, usually within 24 hours, and reaches a really nice threshold within a day of placement of the restoration and setting of the material. And typically speaking, we see less pulpal irritation and inflammation around glass ionomers than we do other types of materials, resin composites specifically. No material, or especially glass ionomer, is not going to be great to be used as a direct pulp capping material, but when you talk about an indirect pulp cap, glass ionomer type of restorative materials work really, really well. They're bulk fill. Bulk fill composites are very popular now, and glass ionomer is really, one of the first bulk fill materials that we had, where you didn't have to incrementally fill and could fill an entire, preparation with one increment and either dark cure it or in the case of like a Fuji 2 LC, something like that, light cure it as well, and not have to play the game of incremental fill. Another part or another aspect that we see of glass ionomers that really we can take advantage of or is very beneficial for our patients is the fact that after a glass ionomer restoration is placed, we see more of a seal at the interface between the restoration and the tooth. And a big part of that is that we really don't have much, if at all, polymerization shrinkage of glass ionomers versus that of resin composites, right? So you place a resin composite, you have polymerization shrinkage, you get some opening of that restoration tooth interface that can cause some sensitivity and bacterial leakage and stained margins and all that. And you get much less of that with glass ionomer. And that's what the thought is that because there's no polymerization shrinkage or orders of magnitude less than resin composites. So those are 6, I think, advantages that you can find about using a glass ionomer restorative material. I think it's important to think about, what they call the spectrum, so to speak, or the continuum of fluoride releasing materials. So if you had a continuum of kind of all the materials that are available for us, what we're looking at right now is the very sort of far end of higher releasing fluoride materials between glass ionomer and resin modified glass ionomer. If you were to move towards less fluoride release, you'd be moving way towards your right, like way off your screen, out of your office, into the next room, when you start talking about geomers, compomers, and resin composites. GIs and RMGIs sort of stand kind of off on their own towards the higher fluoride release, and it just really trickles down to zero as you start moving through the geomer, compomer, and resin composites. So glass ionomers originally, as they first came out, were traditional glass ionomers, full glass ionomers, and that a lot of fluoride release, but they wore pretty specifically, especially we're talking about using basically glass ionomer cements as restorative material, mixing them up and loading them into a lesion. They wore pretty greatly, like upwards of 70 plus microns a year, which is a lot. And they just didn't handle very well, which is kind of the experience I had with my very first restoration, right? I just couldn't handle that material well to put it where I wanted and keep it there. and let it set and not have a big mess everywhere. So, as those were kind of issues, what did the company start to do to sort of combat that? And that was adding resin to it, right? To create resin modified glass ionomers. And so along with that, we got better wear. We had less wear, less than 70 microns a year, which is a lot. We start getting below that into the 40s with some of the early RMGIs. They handled better because the resin was a little bit easier to put where you wanted it and keep it there. They looked better. They polished better, had better shading and better matching. But along with all those things is we got less fluoride release. So it's a give and take, trying to find the right happy medium of being able to handle well and wear well, but still get that release of fluoride that we really want, right? So, I think it's trying to find the right material for you and your patient in the application. Now, one of the materials I'm going to show you later sort of thankfully takes some of this decision out of our hands and gives us some great qualities without sacrificing that fluoride release. But this is always something to keep in mind. The more resin that gets added to the glass ionomer, the less of that positive stuff that we see like fluoride release as time goes on. So here are kind of the typical direct restoration applications of glass ionomer that you could use in your practice. And we're going to go through each of these, some of these very quickly, some of these a little bit more in depth, and talk about each one and where a great, where you can find some places to use these materials. First thing is to talk about a base and a liner, and whether or not you use a base or a liner under your restoration almost specifically depends on when you went to dental school. There are definitely generations of dentists who specifically were taught and still practice bases and liners. Now that wasn't my generation. We were sort of through bases and liners when I was in dental school and in restorative dentistry, but the generations before me really, were brought up to use some sort of base or liner, and glass ionomers work great. That term is often used interchangeably, a base and a liner, and technically they're not the same thing. A liner is going to be a very minimal thickness, mainly like an indirect pulp cap is really what a liner is. You need to be seeking some sort of benefit to the pulp, some sort of pulpal soothing or trying to get a secondary dentin bridge. That sort of thing is what a liner does. It's going to be a very thin layer, and it's specifically going to be with the intention to specifically target the pulp and reduce inflammation, reduce any kind of pulpal irritation that you may get. So that's a liner. A base, and the liner is going to be on the left of your screen. That's typically what a liner would look like, whereas a base on the right is used in a thicker layer in an effort to reduce the amount of the ultimate restorative material. So basically, reduce the thickness of the gold inlay or onlay, like you see in this photo here, or reduce the thickness of the composite that goes on top of it, anything like that, right? So a base is going to be thicker. You're not really looking for any pulpal influence here, and specifically speaking, just to try to make your life easier with your penultimate restoration, whatever that may be, whether it be amalgam, gold, resin composite, whatever. So let's use those kind of terms. Let's not use those terms interchangeably because they are different things. Both of the materials I'm going to show you at the end would work great in either of these situations, a liner or a base, and are great choices for those. If you think about sort of some of the bulk fill materials that you see now, the bulk fill resin composites that ask you to, use this one specific resin composite that flows in, and then leave it a couple of millimeters short, and then cap on top of that with your nano hybrid or your micro hybrid composite. That would be the same idea as this, right? So you could definitely use a material like this instead of one of those bulk fill composite materials, and probably get better properties in the tooth for the patient than you would with one of those materials. So let's talk about core buildup right quick. These glass ionomers can work really well for core buildups. I think the biggest issue that we have is that really the data tells us that half of the tooth should remain if we're going to utilize a glass ionomer for a core buildup. This isn't something you're going to use if you're missing, 3/4 or 80% of the tooth and are going to put a post in it and that sort of stuff. Not an ideal situation. You're looking at Miracle Mix being used here as a core buildup in the anterior to go under a PFM. Which is certainly, an older school of dentistry for sure, but about half that tooth remains. We don't have any pulpal issues here, and so this, would work very well to just, round out and give us good prep form. And glass ionomers work great for those types of situations. And either of the two glass ionomers I'm going to show you at the end today will, work great in this situation as well. We sort of laugh at this now, looking at Miracle Mix being used as a core buildup, because we think like, geez, I hope the ceramist is good to be able to block out that gray material. But this particular slide is from the days of PFM, and so we didn't have to worry about that stuff. But the world exists still today where we are going, where you can still use these materials very well for core buildups. Class 5 is a great application for glass ionomer, especially in the posterior. These materials work really well for that and work just as good, if not better, than resin composites. So if you look at the study here from Franco, big study, 5-year performance of resin composites versus RMGIs, 96% plus of glass ionomers were retained at 5 years versus, just over half of resin composites. Part of that has to do with modulus of elasticity. Part of that has to do with the coefficient of thermal expansion. And part of that, honestly, has to do with that ionic bonding to dentin, which, generally speaking, in a class 5 scenario, is what you're going to be faced with most of the time. It's rare that we find a very heavy enamel-laden class 5 lesion. So for a carious class 5, I don't think there's any doubt about the fact that glass ionomer is the way to go for a patient with a carious class 5. Carious class 5 lesions are difficult, they're tough, they're hard to manage, recurrent decay is hard to manage, and any little benefit we can get is a great advantage for us. And so I think glass ionomer in these situations, anytime I have a carious class 5, it's glass ionomer time. If I have a non-carious cervical lesion, an NCCL, and somebody who has a high to moderate caries risk, I'm probably going to use a glass ionomer for those as well, because of the high caries risk or the moderate caries risk, and we don't want them to start getting recurrent decay, around a composite. When you're prepping these, and a little bit of prep probably is a good thing, just a 90-degree prep, similar to amalgam. You just don't need like a retention groove like you would place with a 33.5 burr if you were doing a class 5 amalgam, right? The other issue with this is you don't really want to bevel your enamel, your occlusal part of your class 5, because that bevel on enamel is not really going to help you at all, because you're not getting enamel bonding with a GI or an RMGI. So just leave that at 90 degrees and, kind of roughen up that sclerotic dentin and proceed. And these work, really well for those and hold up very well, even better than resin composite. Here's a case. We have 2 class 5s here, and kind of one developing on the maxillary first molar. We have a class 5 that's a 1.5 millimeters deep. Probably about 1/2 millimeter on the second premolar, and on the first premolar we have a 1.5 millimeters deep, and those are the points at which you need to start thinking about restoring these, is when they get to 1.5 millimeters. And so these are a couple that have been restored with 2 different restorative materials that I'm going to show you later, and these work very well. Would I use them on a number 8 or number 9 or number 10, an anterior incisor on the maxillary in a high smile line patient? Maybe not. I would maybe try the open sandwich technique again there, with the skills that I have today, or use a resin composite there just with really good isolation. But for anything sort of posterior to a canine, these work tremendously for class 5s, and really, we should be thinking about that and using these in that scenario. The next is the open sandwich technique, specifically related to class 2s, although the same idea really holds true for a class 5. It's not that much different. But for class 2s, I think this is an area where I think too much resin composite is being placed deep in gingival boxes that will never get cured, and polymerization shrinkage is a problem, and contamination is a problem, and we'll get recurrent decay there. So for deep class 2 lesions, especially ones that get down onto root surface, you know, I'm just elevating the margin with the glass ionomer almost every time, just because I know that material is going to perform better down there than resin composite ever could. So you place the glass ionomer in the floor of the gingival box with some type of matrix on. I'm going to show you what I use and how I do it in a moment. And then you would place a resin composite over that. You could certainly place an amalgam over that if you wanted to as well. And those restorations hold up very well. But let's be honest, it's 2018, you know, you're doing glass ionomer in the floor of the box, and on top of that, you're doing resin composite, right? So that's how these are going to go. The glass ionomer in that scenario will provide fluoride release and recharge in vulnerable areas where resin composite would not perform well, right? Resin composite is not going to do well in the floor of a gingival box where you're down on root, you know, where you're deep down, where isolation is difficult and all that stuff. Resin composite is a recipe for disaster there. So we can lift the margin with some glass ionomer and then get it to where it's a nice super gingival margin where we can isolate really well, and we're in enamel, you know, all the way around except for in the gingival, and have a nice restoration that will hold up very well. The resin composite's the aesthetic part, and it's going to be bonded to enamel all the way around, and so it's going to work really well. So this is kind of the best of both worlds when you look at this. You get the strength of resin composite on the occlusal and the benefits of having glass ionomer, you know, down in the floor of the box where is the difficult spot. So you know, this is kind of the illustration that we look at when we think of a open sandwich technique. You know, glass ionomer to, you know, raise the margin. You want to stay below the contact area when you do this, and then you're going to have resin composite all here on the contact, and above that on the occlusal surface. You can even certainly do a layer of RMGI over the pulpal floor if you need to. You're going to get some pulpal relief with that, you know, reduce some inflammation, all of that sort of stuff. So when you think about an open sandwich technique, this is what you think about. Is it an extra step or two to do this? Absolutely it is, and it's time consuming, and unfortunately there's not really any additional coding that you can do to get reimbursed for this. But I think in the situation like the one I'm going to show you, it's the right thing to do. So spending a couple of extra minutes doing this is going to I think be a great benefit to your patient, which is, you know, I think going to benefit your practice in the long run. So, you know, here's a tooth, and you're going to see why this contact is not open in just a minute when you see the actual situation. But you know, when you see decay like that on down basically on a root surface and this low on a tooth, you know this is going to be a difficult restoration to do, right? Not only is this going to be a difficult restoration, but in a bonded world, that's going to be a difficult long-term solution for the patient. So, you know, this type of scenario will hopefully help answer a couple of those different things. So, you know, get your rubber dam on. And get it all cleaned out, and you can see we're pretty much all cleaned out here. You can kind of see that weird contact situation. We got this really strange flat contact here on this second molar that is going to be somewhat difficult to restore. Now I've got a miniature band on this, and this looks like it almost goes all the way up to the occlusal margin, but it does not. This only goes to the this only goes up a couple of millimeters or so. So you know, this is what I call a margin elevation band. Several companies make these. Garrison Dental makes these, and they're very nice. But this little thickness here just allows you to elevate the margin, and then you would switch to a segmental matrix after that, right? So we have the margin elevation band on, and we're going to use some glass ionomer, in this case Fuji Auto Mix LC, which I'm going to show you in a little bit, down in the floor of that box. And once that is set and cured and ready, we're going to remove that. You can still see some roughness and whatnot here. We've still got the amalgam in here I've got to deal with, and maybe a little bit of D-man right there. And now I'm going to clean that out the rest of the way, smooth this out a bit. Now we've got all enamel margins all around here. And the only area we don't have enamel margins, we have glass ionomer here, resin modified glass ionomer, that we can bond very well and predictably to composite, and things will do well. So now at this point, you basically treat it like a pretty simple class 2. Throw a segmental matrix on it and restore it with you know, etch adhesive and your resin composite of choice, and this works really, really well. Yes, it's an extra couple of steps to do that, but I think that serves the patient very well, and gives this tooth a chance to not have to prep it down for a crown because of just a little issue here on the distal of the tooth. Primary teeth, I'm not going to talk a ton about. I'm not a pediatric dentist. I don't see a lot of pediatric patients in my practice, but glass ionomer materials are a great choice for pediatric applications. Caries risk-wise, speed-wise, they generally speaking, you can move pretty fast with glass ionomers. And so that, speed is of essence when you're talking about pediatric applications. The fluoride recharge and release is greatly beneficial. And also knowing that, hey, we don't have to get 30 to 40 years of service out of these restorations allows you to use glass ionomers, especially a couple of the ones I'm going to show you later, in occlusal and class 2 situations in pediatric teeth. And so, that's a really great use of this material in your practice, as opposed to composite, which probably, for pediatric applications is a little bit tougher. Trying to get that really great, perfect isolation is tough. So I think glass ionomer is a great thing to think about, when you're trying to restore carious primary teeth on a kiddo. Let's talk about hypersensitivity. And so I want to show you this case. This is Corey, and Corey came to me from another dentist in town, and they had this DO composite on number 29 placed. Small DO composite. Certainly not deep caries. We're somewhere close to 3 or 4 miles away from the pulp here. I mean, this is, not a restoration that I would guess would cause the patient a bunch of post-operative issues. But ever since the composite went in, the patient has just been having a ton of issues with cold sensitivity. And so in that scenario, when I have, a tooth with a resin composite that has that type of cold sensitivity right after placement, generally speaking, I will take out the resin composite and replace it with a glass ionomer. And I always talk to the patient about this, like, hey, what we're putting in this tooth is not a 30-year restoration. It is a restoration that will last for a few years, and the point of it is try to get the nerve, trying to get that sensitivity, that pulpitis calmed down, and then we can re-restore the tooth with its long-term definitive restoration after it settles down in a couple of years. And so this particular PA was taken in 2015 when we replaced this. And so I replaced it with a material called Equia Forte. You can see here a little less radiopaque than traditional composite would be, but still readable on a radiograph. You can still tell it's there. And now that distal of 29, this restoration is still there today, still looks great. This bite wing was taken maybe 6 or 8 weeks ago. So it's still functioning. It's been in the mouth for over 3 years now, still doing well. Almost immediately the patient felt better. Like within a day and a half, the patient, all of their sensitivity was gone. After getting the composite out and replacing with glass ionomer, almost all the sensitivity was gone. So glass ionomers are great for these types of patients that get really sensitive after a resin composite's placed. You get that resin composite out of there, replace it with a glass ionomer, they're going to feel better right away, and you become a hero. And I think just it's our duty to inform them, like, hey, this isn't a 30-year restoration, but we will take care of a definitive restoration once we get this tooth calmed down. And at some point in the next few years, I'm going to have to, take this restoration out and replace it with hopefully a more successful resin composite, right? So this is a great area to use glass ionomers, especially one of the ones I'm going to show you in a little bit, and really be a hero to our patients who have been suffering, either with a restoration that another dentist did and now you can look like the good guy, or you can save yourself if you did a restoration that has gotten sensitive after placement. So I think this is a hypersensitive teeth after resin composites is a great area to use glass ionomers on. And finally, as the last application before we get into the actual nuts and bolts of the materials themselves, I want to talk about caries control. And I want to show you Sydney. Sydney was a patient of mine, and Sydney's the highest caries risk patient that I think I've ever seen. At least the highest caries risk patient that I've ever seen that didn't have some sort of underlying medical condition like a Sjogren's or something like that. Sydney was just a teenager. She was, I don't know, probably 16 years old when I started seeing her. Did a bunch of restorations. You can see a lot of them here. And actually, this is after they've been done a second time. All of these, this was done a second time. So the first time, Sydney came in, we did a bunch of restorations. She had a bunch of decay, did a bunch of restorations with resin composite. couple years later, she comes in, she's in on recall again. We take another set of radiographs, and we see recurrent decay around some of the restorations I just placed. So I felt really bad about myself, and really kind of came down hard on myself, like I'm going to have to do, and thought to myself what a crappy dentist I was and whatnot. So we brought Sydney back in, and I put a rubber dam on and replaced all those restorations under a rubber dam. And then this is 2 years after that. So this is 2 years after a lot of these restorations were placed under rubber dam, and you can see how much decay she has, plenty of it around restorations that I literally placed less than 2 years before under a rubber dam with great isolation, right? So in our minds, we blame ourselves about this, right? We think, man, I just must not be any good, whatever. But really, the problem here doesn't lie with us as dentists. The problem here lies with the host. It lies with Sydney, right? But we have a hard time handling that and accepting that. And so, at this point, I re-restored Sydney again with resin composite under a rubber dam, quadrant at a time, just like Summit taught me to do when I was in dental school, and just like we taught students to do when I was teaching in restorative dentistry. And thankfully, Sydney moved to Washington, D.C. So geographic success on Sydney. There's some prosthodontist in Washington, D.C. that's having to deal with all this still, and probably feels just like I do, after he's done some ceramic inlays or onlays or crowns, and had a failure or two or three, that he feels pretty crappy about himself. But it's the issue's not with Sydney. Here's her anterior teeth, and you can see, basically just kind of decay all the way across, right? And this is after they've been restored and had, multiple restorations in them. And just for posterity's sake, here's the lower anteriors. And you just know when you see this kind of decay on lower anteriors that this is just a patient that resin composite's going to fail on. And there's a few reasons why resin composite's going to fail on this patient. Number one is isolation has to be absolutely perfect with resin composite on a patient like this where the margin of error is so thin. This is a razor thin margin of error on a patient with this type of host response. So that's an issue. Polymerization shrinkage is an issue on her. Any type of micro gap that forms at a margin is going to turn into decay. There's a lot of patients who probably have much bigger micro gaps that aren't a problem because their caries risk isn't so high. And also resin composite is almost like a magnet for bacteria and plaque. And I don't know if you've noticed that before, but patients who have some issues with home care and form a lot of plaque and have plaque removal issues, areas where you do resin composite, you can almost see the plaque just like having a Thanksgiving feast there right around the margins of that resin composite. And that's because resin composite attracts plaque. Plaque sticks to it very well. Part of it's the surface roughness at a micron level versus enamel. Part of it's some of the chemicals that are in there. But resin composite is just really a plaque magnet. And so when you take somebody who's high caries risk and you fill them with composite, they're just going to have a real issue with plaque, and where that plaque builds are going to get recurrent decay. And so, this is Sydney. She was, at the time we started, she was, 16. By the time I finished with her before she moved, she was 18 and a half or so. And she really needed amalgam is probably what she needed. But she was an 18-year-old, 16, 18-year-old female. She was an actress and big in theater club in her high school and whatnot, and there's just no way her or her parents were going to let me put amalgam in her. So I bit the bullet and put composite in and did it a few times because I was dumb. This is a patient where glass ionomer can make a real difference. Now we all know that if you look at like this mesial of 18, that certainly glass ionomer doesn't have the strength to hold up there for any type of long-term type of restoration. But if you use glass ionomer in a high caries risk patient like this where you have multiple failures, and then go through all the hoops that we need to jump through with her, if you think about those like being heavy oral hygiene instruction, frequent recalls with hygiene, some sort of sodium fluoride containing dentifrice like MI paste or Prevident or Clinpro, 5000, any of those 5,000 part per million dentifrice toothpaste, frequent fluoride varnishes, chlorhexidine varnishes. I mean, just the kitchen sink, whatever you can throw at this, you throw at this. But hopefully you can maybe get her out of her high caries risk time before you have to restore this with a more definitive material like composite. So maybe you can flip the equation with her while she's in glass ionomer, and then as she's a better patient, as that host, as those host issues have been worked out some, hopefully then you can switch them instead of just chasing your tail with composite after composite after composite. So if I were doing this case over again, or if I saw a patient like Sydney today, I'm going to show you in just a minute the material that I would use for this case to try to prevent this. Knowing full well and informing the patient, hey, these restorations I'm going to put in you are not going to be 30-year restorations. When I'm putting them in class 2 and class 1 situations, they are going to be restorations that we are going to use to get you through this high caries risk time. We're going to try to flip the script with whatever adjuncts, whatever home care, whatever hygiene type situations we can do. And then once things are looking better and the equation is more set up in our favor, then we will restore these with a more definitive material. So that's what I mean by caries control. I mean, using glass ionomer instead of composite in these super high caries risk patients while you manage their caries risk and try to get their caries risk down. That's kind of what I'm talking about there. Mickenouch has this study that I talked about earlier that's a pretty high level study, a systematic review that really has a whole lot of data in it. And basically a single surface glass ionomer restoration has 65% lower chance of getting recurrent caries around it versus amalgam. So can you imagine what that would be versus composite if this study were done today, right? And I think it's going to be even more than that. So, I think this goes to answer really what kind of effect the fluoride recharge and release can have in our patients. So, this is a high-level study, and I look at this, and there often gets to be, some debate in the literature about the effectiveness of fluoride recharge and release, and I think this kind of answers it right here because this is a super high-level study. Again, there's other studies that show that the fluoride recharge and release isn't that big of a deal, but when you look at the way those are laid out, they're typically not laid out really well, and there's not much isolation of the groups as far as caries risk and things like that. And in this particular study, there really is. There's a big delineation to make sure we're comparing apples to apples and not oranges and apples. So let's talk about the kind of two new materials on the market that I've been alluding to this whole time. And these are materials that one of them has kind of been out for a couple of years or so, but still a lot of people haven't used it, haven't heard of it as much. And then another one that is really, really new. And Equiforte has been around for a few years, and it's really a great material. And Fuji Auto Mix LC is a material that's come out relatively recently, like within the last couple of months or so. And it works really well as well, specifically in some of the situations we're going to talk about. So Equiforte is a little bit different. We talked about at the beginning of the webinar tonight about the sort of fluoride material releasing continuum, and that true glass ionomers, released and recharged more fluoride than resin modified glass ionomers. And so, if you're looking at fluoride recharge release as being, a real driver to when you're using this, so caries control patients, that kind of stuff, Equiforte is a great choice because it really is, from a fluoride recharge release standpoint, there's no resin in this material, so it behaves much more like a glass ionomer. The difference separate this from like a Fuji 9 or one of those really early pure GIs that we would have used in dental school is that this has a very nice ceramic filler in it that gives it a much higher flexural strength and much higher wear resistance than like a Fuji 9 or a more traditional, pure glass ionomer. Also a higher acid resistance. We do have 8 shades in this, which is pretty high for glass ionomer. Typically speaking, there's not that many shade choices, but you do get a decent amount of shade choices here. And so where I would use Equiforte is caries control type of situations. This is the material I used on Corey, who had the super sensitive class 2 that we redid, because this material will actually hold up pretty well in a class 2 scenario. And this material also works really well in a class 5. This material works really well in a core buildup. Pretty much anywhere that we've talked about it, Equiforte works great. And you know, when I was in dental school, it was kind of verboten. I mean, it was almost like, you know, you were locked away in the brig, and the key was thrown away if you suggested even thinking about putting a glass ionomer on a class 1 or class 2 lesion. And if you look at this study that was done in Greifswald, Germany, a 4-year evaluation done, 1,000 fillings were done with this Equiforte, class 1s and class 2 situations. At a 4-year recall, only 3% of Equiforte restorations done in class 1 and class 2 situations had fractured. And so, you know, this is a pretty big study that shows, hey, you know, at 4 years, 5 years, somewhere in there, you know, you can use some of these, you can use a material like Equiforte in the right scenario in a class 1 and class 2 situation. You know, why has it worked so well on some of these patients? Why has it worked well on Corey, the patient I showed you with the sensitive filling? And I think part of it is because it's small. You know, you've got to pick your cases to be small to moderate ones to use this. Do you remember that number 18 big MO on Sydney that you saw that was, you know, going to almost probably need endo? You know, that's one where you could maybe use this in a sandwich technique, or you could use, you know, fill the whole thing with this, just knowing that, hey, you're not going to get that much time with it as you may have, you know, with a smaller one. So size is definitely an issue here. The smaller the better when you're doing a class 1 or class 2 with Equiforte. The technique guide on Equiforte is pretty easy. I've always found this interesting, the optional step of the GC cavity conditioner, which is, if you remember from biomaterials, polyacrylic acid. The interesting thing about polyacrylic acid is that there's not a ton of good literature that shows that it really makes a huge difference in our restorations. What polyacrylic acid does is it just sort of frees up some of the calcium ions in the dentin so that we get a better chelation between the glass ionomer and the dentin, and so we get, you know, hopefully a stronger bond. But the literature doesn't hold up all that well that it makes all that much of a difference. There was one study that showed that restorations that did not use polyacrylic acid had slightly more staining at the margin. So, you know, if you look here, it says optional, and that's because, you know, there's not great literature to support the use of it. I still use it. I think part of the reason I use it is because I just love that aqua color of it. It reminds me of the Carolina Panthers, and there's really no other material in dentistry that gives you that true kind of aqua teal blue color, and I just like to see it. So really, in all joking aside, I use the polyacrylic acid because that's just what I did in dental school. And, you know, we were always sure to use it in dental school, and that tradition kind of carries on. So it's more about that than anything. You're going to gently dry it. You don't want to over dry this. It's a lot like composite. Over drying is bad. Tap the little button in, depress the plunger, throw it in a triturator or an amalgamator, and that seems to be the problem with this material, is that many people do not have amalgamators anymore or mixers, and I totally get it. If you're opening a practice, a new startup today, and you've got 500 things to order, I totally understand why you don't want to spend $1,500 on a triturator or an amalgam mixer, an amalgamator, whatever you call it. I totally get it. And if that's the case, if you absolutely don't want to have one in your office, the material I'm going to show you next will overcome that. I did a startup in 2009 and didn't have an amalgamator or triturator, and I ended up getting one on eBay for about $100. So at worst case, check on eBay. I think it's important to have one because I do use this material in different places than I'm going to use the Fuji Automix LC. And in specific, the caries control cases are great for this. The sensitivity cases are great for this material specifically, partly because, you know, those are cases that are more likely to have occlusal contacts on them, and so this material is definitely going to hold up better than any other glass ionomer in those scenarios. So you mix it, load it up into your applicator, your glass ionomer applicator, and then you take it to the tooth and bulk fill it in. You do some minor shaping. You know, is this going to handle like a G anneal, you know, really nice high-end nanohybrid composite? no, it's not. It's going to be more runny than that. It's going to be a little bit, harder to carve anatomy into, while it's still setting. And here becomes another issue with this that's not really an issue, but it's just something you have to know, is that this is a dark cure material. This material does not light cure. Equia Forte, you can hold a light on it for 30 seconds. It's not going to do anything. It's got a dark cure. So 2 minutes and 30 seconds is the amount of time you need before you can start finishing this with a burr. Personally, I think 2 minutes and 30 seconds is a lot of time. So I have to leave the room. I have to go do a hygiene check. I have to go check my email. I have to go on Facebook and argue with somebody on one of those dental Facebook groups about something stupid. I have to do something to get out of the room. Otherwise, I'm going to try to finish it before it's ready. And when you put a 7404 or a 7901 burr on this material before it's ready, it will like vaporize, and you will over finish it very easily. So it's a dark cure material. It doesn't light cure. You got to get out of there and give it a chance to set. So try and keep the patient as isolated as possible. If you have a run on rubber dam, great. If not, just really have your assistant stand there and work on keeping them suctioned and dry, and leave the room, let it do its thing. Then you come in, do your occlusal adjustments, finish it down, shape it how you want it, put in your anatomy, and then you throw on this Equia Forte coat, which is kind of a resin coating that goes over it and really kind of seals the margin, seals the interface, puts a cover over the material to buy you a little bit of time before the patient's actually wearing on it with their occlusion. You light cure that and they're done. You don't even need to check the occlusion again. So that's the typical technique guide for Equia Forte. I think the biggest barrier for many people is the fact that you got to have an amalgam mixture. Here's the Class 2 cavity prep guide. And so when you look at this, this is going to limit you to some of the types of restorations that you can use this on, right? So you really need to have a horizontal floor of the box, right? Sometimes we have to do these types of kind of sloping down, sort of feather edge type of gingival floors. And in this scenario, you would want to use a glass ionomer as in the gingival floor of the box and do resin composite over it. That will work really well. But when you have a platform like this, it really gives us problems occlusally with this material. You also don't want this material really over bulked. You want this to really follow the contours of the tooth and not kind of have sort of a cantilever-ish type of over contouring there, because that unsupported material is going to break. So a sectional matrix is really a must on these types of scenarios. All your internal line angles should be rounded, but that's typically for every type of restorative material we do, from everything from resin composite to Emax to zirconia. Rounded internal angles are a great thing. Sharp internal angles are bad for almost any material, so be careful about that. And you really want to, you've got to stay inside the cusp peaks here. So if this is your scenario, then I would put Equia Forte in the floor of the box and then use resin composite on top of it, right? But if you have a scenario like this, then Equia Forte will hold up really well, especially if you can keep the occlusion off of this area and keep the occlusion on this part of the tooth, right? On the part of the tooth that's got natural enamel. So here's a case done by my friend Zach Miners in Independence, Missouri, of a very nice Class 1 lesion. We see lesions like this all the time, restored with Equia, and going on a few years strong now. So this material in the right situation, if you pick the right cases for this, this will hold up very well. If you can control your occlusion, this can hold up very, very well. And in scenarios where you can't, you just know that you're going to have less time with this material in order to get their caries controls issues under control, to get their sensitivity under control, whatever it may be. So this is a Class 5 done with Equia Forte. I believe this is shade A2, and this material holds up well. It polishes pretty well, and I think it looks fine. In this scenario, would I have used this material on a Class 5 on number 9 or number 8? No, absolutely not. That's not what it's for. Not what it's for. Here's their new GC America's newest product, Fuji Auto Mix LC. This is a resin reinforced glass ionomer that's light curable, right? That's what the LC stands for, is light cure. It's much more radiopaque than Equia Forte is, and it differs a little bit from Fuji 2 LC in that we have smaller filler particles, which gives us more fluoride release, and it also makes it a more aesthetic material. The smaller filler particles polish better, and so we don't have that same roughness that we used to have even on well-polished glass ionomer. This this tip here that you inject it with, has this nice little tiny lumen here so that you can really get this where you need to get it, because a lot of times you're using this material in tough areas to get to, right? In those open sandwich techniques and carious class 5s in the back of the mouth, right? So you need to be able to get this there with some precision, and this tiny applicator allows you to do that. It only comes in 3 shades, so it's not nearly as aesthetic as a material as far as your options go. But those 3 shades work well, and this little ergonomic dispenser gun really kind of sets this stuff apart. With Fuji Automix LC, you do not need to have an amalgam mixer. You don't need to have an amalgamator or a triturator or anything like that. This mixes all in here in this tip, and so that takes the equation out of it. So if you don't want to have an amalgam mixer, then this is a great GI material for you to use. And this is the gun itself. You use this, kind of pull these things out of the way, load this thing in, pull this little white cap back, and then you slide the tip on, slide this little white plastic back over it, and that tip locks in, and we'll mix your paste for you. And here it is without the mixing tip on, and you can see this is just 2 syringes of paste that get mixed together. So when you're not, that's what kind of sets these 2 materials apart, is neither of these materials are hand mixed, and so hand mixed materials just incorporate a lot more air, a lot more user error in them, and really and honestly, we're just not used to mixing materials anymore. Everything's auto mixed now, and so that's why these materials I think hold up well, is because we're not relying on a really skilled mixing regimen. So to use this ergonomic dispensing gun, you pull the piston back, load this thing in, kind of twist it in, let it go, bleed it a hair, throw on the tip, and now you're lock it in and you're ready to roll with this. And it actually does. It is very ergonomic. Doesn't take very much hand pressure to exude this out and extrude this out, and you can really get it into some really tough places into the mouth without too much problem. Here's your restoration guide, right? So you see they've recommended this for class 3s, specifically probably where there's non-occlusion, class 5s, and primary teeth, right? And also as a base for a class 1 or class 2 for like an open sandwich technique, right? So here's sort of what you do. Both of these talk about using the cavity conditioner. We've talked about that before. Whether or not that is all that effective is to be debated, but I still use it. And this is Fuji Automix LC, and it looks pretty good, especially for being, one of only 3 shades that they make. So as Anthony says here in the questions, nobody needs more than 3 shades anyway. So I think that's probably right. So today we've talked about the advantages of using glass ionomer as a direct restorative material, and all the different benefits that we get from using it. We've talked about the applications of using glass ionomer in a restorative practice, and maybe some areas where you can use them some more. And we've talked about the techniques on Equia Forte and Automix LC, Fuji Automix LC, which may be some of the newer glass ionomers that are on the market that you may or may not be all that familiar with. I'd like to thank GC America for their support of this webinar. I think they're a great company. They had no influence on the content of this program at all, but they did support this through the Viva Learning platform. So I'm going to do a couple questions right quick. Gordon asks, being light cured, does Fuji Automix have to be placed in layers? And so let's go back here to our technique guide, and you can really do this really in a bulk fill in most scenarios. This is you want to try to keep it in increments of 2 millimeter. I certainly wouldn't go up to like 4 or 6, but in most scenarios, especially like a class 5, 2 millimeters is going to be just fine. You're not going to have any issues with that. Most of the time you're going to be good. And if you're using it as a base or something like that, 2 millimeters is kind of all you need, and then you're going to use a definitive restorative material on top of that. So, and in an open sandwich technique scenario, same kind of thing. You're just not going to need more than 2 millimeters most of the time. So yes, probably, you're going to have to do this in layers, but that's probably not going to affect you too much at all. What about thermo-curing the GI for 1 minute to set it thoroughly after placing? So, for a light cured material, that's not really anything you're going to have to worry about. For a chemical cure, or a dark cure like Equiforte, I mean, that's what you're doing. You're allowing that. So the 2 minutes and 30 seconds is plenty of time. So you don't need to let it sit for an additional minute after that. Let's see here. Is Fuji only light cured, or is it dual cured? It's only going to be a light cure material, and so you're relying on your light to get to it. So do that that way. And same question here again from Robert. So the Automix LC is a light cured and not a dual cure material. So be careful with that. Make sure you put your light on it. Don't let it just try to dark cure, because it won't. So it does get kind of confusing with these, I know, because just the different curing applications. But just look at the title. If it's got LC in the title, then you got to put a line on it. Julianne asks, would Fuji Automix replace Fuji 2 for class 5s? In my hands it would. I think it handles much better. It's a really nice handle. There's no mixing involved, either with a capsule or by hand, so I love that. The tip has very, if you're at cross section, the mixing tip on there, the filament takes up most of it, so there's very little wasted material with it. So absolutely, I think it looks better, handles better, polishes better, and is easier ergonomically on me and my assistant than Fuji 2 is. So absolutely. Let's see. Robert asks, have you done caries control silver diamine fluoride and covered it with resin modified glass ionomer? Yeah, so SDF is kind of the newest, that's the new sexy thing to talk about when it comes to caries control, right? And I think the data on it's really good. The UC Berkeley study on it really showed great effect. And so we have some problems with it turning dark and things like that. And so certainly you could do that, and that's Sydney probably needs that kind of care, right? You're going to have patients that are going to need sort of everything we can throw at them, and I think SDF is a great thing. So I have no problem putting SDF down and then putting a glass ionomer over it. Yeah, are you going to see some darkness through it? Certainly you are. Specifically using this on posterior teeth, and so I'm not as worried about that. I had a pediatric dentist call me, and said, hey, they're referring a patient to they're referring a patient to me for a crown, and he did the same thing. He did SDF and glass ionomer over it, and just wanted to give me a heads up because he didn't want me to think that he left all this gnarly black decay underneath it. And it's like, these are conversations we're going to have to start having with either our patients or the dentist that they go to after us or whatever, so that they don't go in there and ravage that stuff thinking that we just left a bunch of stuff behind. But I think as SDF develops more, we're going to get SDFs that don't stain. We're going to work that out chemically to where we have some SDFs that don't stain, and I think some work on that's already being done, so that will really answer a lot of those problems. Robert asked, for Automix, same mixer as Fuji Sim 2. Honestly, I've not used Fuji Sim 2, so I don't know, but my inclination is that this is sort of a special, this is the first time I've held this ergonomic dispensing gun in my hand. So I think this is it. So that's gonna conclude our program for tonight. You guys are great. Thank you so much. Have a great rest of the night. Thanks to GC America again for their support. And if anybody needs to contact me at any time, you can reach me via email, jaustindds@me.com, or any social media channel. Slide right into those DMs at Joshua Austin DDS. You guys have a great night. Appreciate it. Thank you so much for attending.